Afternoon and welcome to the Community Research Academy. We have a wonderful speaker today. He is prepared and ready for your questions and your ideas. We have with us today Dr. Phillip Alcaby, who has studied the history of ethics and policies of public health. In addition, he has written a book, and the book was entitled Dread: How Fear and Fantasy Have Fueled Epidemics, from the Black Death to the Avian Flu. Professor Alcabees' essays on public health topics have appeared in the American Scholar and the Chronicle of Higher Education Review, among other publications. His work on AIDS and tuberculosis policy has appeared in many peer-reviewed journals, including Lancet, Journal of Infectious Disease, and Social Alternatives. Professor Alcabees was on the faculty at Albert Einstein School of Medicine, Yale School of Medicine, and NYU School of Medicine, where he conducted epidemiological research on AIDS and other community-acquired infections. And he has published extensively before joining the faculty at Hunter Urban Public Health, and he joined in 1999. The next voice that you will hear will be Dr. Phillip Alcaby. Thank you so much, Dr. Alcaby, for being our presenter today. Thank you.
Wow, thank you. What an introduction. Now, I don't know if I can live up to all that. Okay, I'm going to do my best. So it's great to see. I guess I can't see everybody. I can see. I understand. If you can turn your camera on, that's great. And but if you can't, I understand. And I know sometimes there are bandwidth problems. I sometimes have bandwidth problems. And so if you lose me, maybe you'll let Agnes know, and she can, and I'll switch to, I'll switch from Wi-Fi to hotspot, and you'll lose me briefly if that happens. But it happens when I'm teaching, so I know it sometimes happens in this house, and I imagine it sometimes happens to you. So, what I will ask you to do is I'm going to talk for a little bit, and then we'll talk together. If questions come up that you want to address, type them into the chat. That way you don't have to remember them. If there are things that you want to bring up right away, so Agnes is going to monitor the chat. And so if there are things that seem like super important to get to right away, Agnes will bring them up with me. And if not, if they don't seem urgent, we'll take everything at the end. We'll start with the chat, and then we can have a conversation. I'm really eager to talk about how grant proposals get reviewed for community-based research, because I feel like for generations, the whole process of getting research grant funding has been a kind of a secret among researchers. So researchers know how to apply for research grants, and other researchers review the grants, but that means it's a closed loop. Only people who are already researchers can get research grants. And I'm really happy to know that there are efforts to encourage community-based organizations and people who are working in communities to apply for research grants, because what I say to my students and my colleagues, if they'll listen, is the people who know best about what research needs to be done. So somebody's okay.
Yeah, I just muted someone, so.
Oh, all right, thanks.
It should be good now.
The people who know best about what research needs to be done to improve community and public health are people who are in communities, not researchers who are in famous medical schools. On the other hand, it's a two-way street. I think there's an obligation on the part of people who know what the problems are in communities to let the ivory tower researchers know what needs to be done. So I really appreciate that CTSC is trying to create such a partnership, and I particularly appreciate Lula May's efforts to make that happen. So what is it one looks at when reviewing a proposal that comes to, say, CTSC for community-based research? This is always a moment of trepidation when I share the screen. So let's see how this goes. Okay, so here's the form that reviewers use when they look at a proposal, whether the proposal comes from a well-known physician at Weill Cornell, or the proposal comes from a community-based research group. We use this same form. And it obviously wouldn't be blank. It would have a title and names. The PI is principal investigator. It would have one, it would be in one of these categories. It's a pilot project with a special population. Novel technology, not so interesting from a community standpoint, although it does happen. Community engagement. And so we're really interested in research projects whose aim is to get communities more engaged. But often what we're looking at is work by some basically sciencey, medical science investigator who's trying to work with some communities in order to start a research initiative. And it's a pilot in the sense that if it goes well, they will use this information to go to one of the national agencies to seek a large grant award that'll fund a big project. So typically we're looking at smaller projects which are aimed at kind of testing the waters to see if the research is going to be doable, so that the researchers can go ask for lots of money to do the research in a bigger way. And in that sense, I think we have a very important kind of doorkeeper role or gatekeeper role. I particularly want to make sure at this stage, at the pilot project stage, that the researchers who are often, they're physician scientists, are doing things in a way that's completely in concert with community needs and is taking advantage of nobody. Because if we don't make sure of that now, then it's going to be all too easy for researchers to go for big federal grants and continue doing them in the same way. I don't want to say make a mistake. But to continue to take advantage of people in a way that I and you, I think, will find untoward, unacceptable. So I feel like this is a really important job. And on the flip side, it's also important to promote that handshake that I was talking about a few minutes ago, that I want to promote research that's done by researchers who have really taken the time to work with people in the community to find out what community needs are, and thought about how to recruit all kinds of potential subjects, not just the usual suspects who are usually healthy and young and more often white than not. It's important. So, okay, footnote, it's important that researchers recruit people from all different walks of life and backgrounds. Why? Okay, you might think, look, we're all the same inside. We know that. I hope you know that. When I was, I don't know, 4 or 5 years old, I asked my father, like, how come, like, what's the deal? Some people have dark skin and some people have light skin. The people with dark skin in those days were called Negroes. That's how old I am. And my father, gave what I think said the only thing that I think anybody ever needs to say about the question of race or ethnicity or heritage, which is like, people look different on the outside, but everybody's the same inside. Everybody wants the same things, and given that, why can't we just take any group of people and do the research and then extrapolate those results and say, okay, this is what we know? Well, the answer is that all too many people, particularly in America, are eager to say that, well, we're not sure that this medication is okay for people who aren't white, because it hasn't been tested. Or they're all too eager to allow research to go on that when research into medications or procedures that might be dangerous to go on, taking advantage, making use of the bodies of people who aren't white. So I think these, as much as although I believe that, I know that everybody's the same inside, that these questions of race or ethnicity or heritage are super important from a standpoint of how the research gets used and how health benefits are or are not delivered. So I want to be really careful about inclusiveness in research. And because I think that handshake is so important, because I think it's in fact people in communities who are the experts on community health, and yet it's often researchers who are the experts on how to best do research, that the handshake between them is most important. I think community engagement is also an important aspect of reviewing. So what we see is a summary of the proposal, and using this form, we review proposals according to 4 criteria: the significance, the quality of the investigators, how innovative it is, and the quality, strengths, and weaknesses of the approach. And we score on a scale from 1 to 9, a 9-point scale, 1 being the top. And that score gets weighed with a score that's given by a scientific review committee to determine whether the proposal should be funded. So I'm going to stop for a moment and just see if you have questions so far. I just want to make sure that we're all on the same page.
There's nothing in the chat for now.
Okay. So is there anything I should go back up and explain better?
Well, I think you did a great job, but if anybody else would like any further explanation.
So you have to, this is what you have to know about my lectures. I am not going to know if I haven't been clear unless you tell me. So, don't be shy.
Alula, I also had muted you because I wasn't sure who was speaking before, but I think you have to unmute yourself if you're gonna say something. Okay, I have from the chat that you were very clear.
Okay, all right. So great. So I'm gonna now, thanks. Now I'm going to share screen and look at something else. So these are the criteria we use on the Community Advisory Board uses when reviewing proposals. So I mentioned these 4 categories: significance, investigators, innovation, approach. So what does that mean? Does this project address an important problem or a critical barrier to progress? And this seems like a no-brainer, but you can't believe how much research gets funded just to like redo something that somebody did before. And so, you know, I guess, look, researchers have to make a living also, but we're really interested here, and I believe all research should be not necessarily groundbreaking, but should start down a new path, or take the next step on a path that's already been started, not just redo what's been done already. Is there a strong scientific premise that we don't want to turn people into guinea pigs for random, for idle experimentation? There needs to be some strong reason to know that what's being studied here is likely to be helpful to human beings. If the project works out well, how will that translate? This is translational research. How will that translate into better lives for real people? That's got to be important. That's got to be clear in a proposal. And when you're writing proposals, this is partly meant as an aid to proposal writing. That's something you want to make clear. So that if we find that what we think we're going to find, then we will work with so-and-so to make more available this, maybe it's an app that helps people to keep track of their moods and be more aware of when they might be in mental distress and to seek help when they are. Great. How are you going to make that available? And once it's available, how is it going to help people? I want to know that. Okay. So significance is a very broad term. For me, significance is about what difference is this going to make to people's lives, the lives of real people. And if it's not to everybody's life, tell me who the people are. You know, people with borderline mental health problems, people with, incipient diabetes, kids who might have ADHD, but haven't been diagnosed. So let me know who it is this is going to be valuable for, and tell me why and how. Investigators, by and large, when the investigators are from the medical centers, their credentials, they have very good academic credentials. But I want to know, is this somebody who's ever worked with a community? Is this somebody who's spent all his or her life, in a lab, and is now trying to do some community-based research because they feel like they're supposed to? Okay, everybody's got to learn somehow, but in that case, do you have somebody with you who's worked in the community, who's worked in this community? I particularly want to see that there's somebody other than MDs among the researchers, because MDs are I don't have a problem. I don't have a big problem. I don't have a problem with MDs as people. In fact, I'm related to one. My daughter is a physician, but let's face it, physicians have a particular way of thinking about problems, and it's not the only way, and it's not always the most engaged way. So I'm particularly happy when I see that there's a nurse practitioner or nurse involved as an investigator. And when I see that among the collaborators are people who live in the community, or people who work with community-based organizations. That's important. Innovation, how is this going to change the practices of the clinical practice paradigms? How is this going to change what happens to you or somebody when they go for care? How is it going to change the way they go for care? If you haven't noticed, the provision of medical care is a big problem in America. Lots of people can't get it. Some people can't get it because they can't pay for it. Others can't get it because they don't know what to say. They don't know where to go, and they don't know what to say when they get there. And you may have had this experience. Lots of doctors talk down to you if you don't say the right thing. And I think the medical industry is getting a lot better about being receptive, learning that they have to get off their high horse and talk to real people. And they're hiring, receptionists and assistants and so forth who can help people to know what questions to ask. But this is part of that handshake. I really want this research to help to reform the practices of the medical practitioners. And so I want to know how that's going to happen. And then some of this is what's is the approach reasonable? Is it the most reasonable way to do this? I tend not to like research that's just aimed at educating people to change their behavior, because to me, anybody's behavior is the outcome of a myriad of factors, many of which are beyond their control. Like, you can tell somebody all you want that they should, make time to exercise, but if they're working 3 jobs and also taking care of small children, that's probably not going to happen. So I want the research to be cognizant of the multiplicity of constraints on the lives of real people. The more so, the poorer those people are. And because it's not, as you might know, it doesn't just suck being poor. It's also hard. It also gives you more to do. So I think that really community engaged research isn't just research that aims to tell people how they should make their lives better and then leaves it up to them, but tries to find ways that help them along. Okay, so I'm going to stop sharing and see, what have I left out? So far, I have more to say. I just want to see what I've left out so far.
I think so far, so good. Well, from my end.
Anybody else? Just about what happens, what do we see in a proposal? What are we looking for in a proposal? I went over too fast. There's a scientific review and there's a community advisory board review at the CTSC. It's not that way everywhere, although I think it should be that way everywhere. Our community advisory board has been really strong, and I'm really grateful to my colleagues, some of whom are here right now, like Jennifer and Lula May, who have been very, very proactive in getting the CTSC to recognize that community advisory board review is just as important as scientific review. I hope this will be a model for all kinds of the review of proposals in all kinds of areas that are related to health. It's a long road, but at least we've started.
Well, I have a question. How do you ensure that people are, I guess, open and diverse and follow that criteria in any ways? Like, how do you ensure that in other programs? So I know that at the CTSC it is diverse, but how do you ensure other people, other programs are reviewing them and are diverse and meet those?
When I said it's a long road,
Yeah.
what I mean is that it's going to take a lot of advocacy at a lot of different levels. Fortunately, for the last 20 odd years, the national agencies have become cognizant. They're requiring community advisory boards for federally funded research. That really flowed out of, in my view, Jennifer might see this differently. In my view, that came out of the uproar over AIDS research and the activities of ACT UP and the demands from ACT UP and similar activist organizations to be involved in determining what research got done and even reviewing the research. So the word is out, but it's a question of, we're really lucky that we live in a city where this tremendous pluralism is kind of taken for granted. We barely even notice. But lots of research gets done in parts of the country that are much more homogeneous. And it's harder then to, for say, medical researchers to recognize that everybody's not like them.
There's one question in the chat. How do you look or encourage social workers and other behavioral and mental health practitioners to be invited to or included on the research team?
So one thing we can do is we can say, when we're reviewing, we can say, it's pretty weird that that you're all doctors and you don't have a social worker, or you don't have a nurse practitioner. I think that's at this level, that's a start. When I talk to my colleagues about research, I encourage them to have multidisciplinary teams. A few years ago, when we were talking with New York City about a very big research project, we really tried to get nurses and social workers involved and not just doctors. So again, I think that's a multifaceted campaign that everybody needs to wage, that we need to say, whenever we know about the formation of a research project, to remind researchers that doctors aren't the only people who know about people's health. So I think I will.
Before you start, that was my question in the chat, and I just want to expound a little bit, and you may talk about this as you go. I happen to be a social worker, and I think about the ways that social workers as a profession are perceived, and that not necessarily perceived as researchers or folks who understand science or could be engaged. So oftentimes it's not just about, like, folks don't, even in the medical community, may not understand the value or role of the social worker, because it's key when you look at community practices. They understand systems. They look at, it's not just a clinical work, it's how folks are going to engage in systems or have access to the implementation of the recommendations. And I think that's a little bit of what you was hitting on, but I just want to expound that that's key. And then I think about it, I don't ever recall in my career the medical community coming to social work schools or universities saying, hey, we're doing this research. And so this sounds like it's an onus on those who are excluded to ask to be included. And so then, it's a way to think about how much more intentional the medical community can be to say, like, this should be, even if we're not sure exactly what the role is, that we need to have folks on.
I wanted to, build on what you just said, Diana, and what you just said, Philip, that, one of the sort of moments of magic in HIV/AIDS work was when the very high expertise, high profile physicians and virologists at international conferences acknowledged how much they needed the practitioners and the people who were living with HIV and the people whose communities had been affected by HIV to be part of the partnership in addressing the epidemic, that really the work could not be done well without engaging everyone. And, you know, to some extent, that insight has been maintained. But as you just said, Diane, you know, when do the doctors actually come and talk with the social workers? When do the nurses, you know, get engaged? When do those of us who are infected or affected by something get drawn into the conversation as essential partners, not as, oh, it would be nice?
So here's some guardedly optimistic news. I don't ever like to be more than guardedly optimistic, but here's my guarded optimism. One is that the medical services have become so complex that medical providers increasingly are employing some kind of navigators or case managers. And often those people have a social work background. Even if it's not an MSW, they are plugged into the social work frame of mind, much more so than doctors are, as you just pointed out. But that has an effect. It has an effect of increasing the visibility of social work to doctors. So that's a foot in the door. The other, and I believe it's going to make a difference, I hope it's going to make a difference, is that the medical industry is becoming female. And we're just beginning to see it, but in another generation, the change in the past generation is dramatic. And in another generation, it will be, I believe, that most physicians, most young physicians will be female. The majority of young physicians will be female. And I think that from what I can see, they take in the instrumental thinking of the medical profession in a different way. They process it in the context of a more caring approach to medicine. That's not to say that male doctors aren't caring, but what I see in medical training is that the women medical students and young physicians are thinking about the scientific part, but contextualizing it in caring. And so rather than those two things being kind of side by side, as they've traditionally been in medical training, it's now that the science is getting contextualized within a context of caring. I hope that continues. I hope that the young women who are blazing trails in medicine right now can kind of take over the field and change it in that way. But if that happens, I think it will create opportunities for collaborations of the kind we're talking about here. So, let's see, but you should, whenever I would also say, look, we're all patients from time to time, and you can use your presence in the medical setting to, applaud the non-physicians and the work that they're doing. And you can, when you work in community-based organizations, you can promote the work of non-physicians, even when they're, or especially when they're engaged in the health field. The health field is increasingly important in schools of social work. There are social workers. Hunter College has a very well-known school of social work, a very good one. And we have new faculty whose field of expertise is health. And that's as it should be. So I think that there's some hope, but it's a campaign. And we all need to stay on top of this and keep on reminding the doctors that the research, as Jennifer said, is better when it involves people who actually interact with the people there who are being researched, and involves the people who are being researched. And that's the next thing I want to come to. So let me just.
I just want to interject, Philip, can I?
Yes.
This is Lula May. That is why this course is so important. And every person that is participating in this course today, they have an important contribution and a role. Their takeaway for this program is to take your information and that steadfastness and that commitment to getting research information out into the community, and for them being the liaison, being the hook that hooks in with the Clinical Translational Science Center and with the community, and bringing them together and including them in the process, getting the community in research, keeping themselves in research, whatever their expertise, if they're social workers, if they're teachers, if they're educators, to use that as the hook to stay involved in research and clinical translational research. And that's why what they're doing today is extremely important. Thank you. I couldn't go any further without saying that. Thank you.
Thank you, Lulu.
I'm just going to refer, sorry, I just want to refer back to the chat. There was a comment question said earlier, referring back to the community. She said, particularly during a pandemic, how important is it for the research team to check in with participants and advise regarding end date of project, etc.? Is there a higher duty of care because of a pandemic?
I suppose, so that's an ethical question, the duty of care. And the great or frustrating, depending on how you look at it, thing about medical ethics is, if you ask a question to 2 medical ethicists, you get 3 answers. There's no strict answer. My feeling is the duty of care is always at its highest level. If you are a caregiver and you're doing research, your research must always take second place to the caregiving. Not everybody agrees. In fact, I wrote an article with a colleague, a nurse practitioner friend and colleague, about 20 years ago, in the context of AIDS research. And we, I think, had a lot of, making this argument that doctors have a duty to care before they have a duty to research. But there was a lot of pushback, and actually we lost. And in medicine, the duty to care is, this is like, someday you can take my medical sociology course. The duty to care takes a back seat to, it's honored more in the breach than the observance. In terms of medical research, that medical research is the big thing right now, and it's really hard to get doctors to remember that they have a duty to care. Does the pandemic increase that duty? So for me, no, because it's already at 100%. But others would give you a different answer. But I want to come to this. I mean, I'm really glad you brought this up, because this is something I actually want to talk about by showing you a proposal that we've got at the CTSC. I'm going to try to keep the researchers' names off the screen. So let's see if I can show you some of this. So this is about people, the people who would be helped are people with systemic rheumatic disease. And the concern is what happens to them when they get coronavirus vaccine. So your question is really pertinent here. So people are getting vaccinated against coronavirus. We know that the vaccination can have some adverse effects. We know that those are rarely serious. But what about in a person with an autoimmune problem that makes their body inclined to respond to immunogens like vaccines with a florid and potentially dangerous reaction? What will happen? So well, that sounds like an important question. And it's a question that is relevant beyond just coronavirus pandemic, because it gets at the whole class of the new class of vaccinations, which are these mRNA vaccines. The Pfizer and Moderna vaccines against coronavirus are mRNA vaccines. And there's a particular worry among rheumatologists, who are the ones who care for people with autoimmune conditions, about what will happen and whether people with systemic rheumatic disease will experience what are called flares. So this study aims to look into that, and I won't go into the methodology. I actually think that there's a scientific problem in the setup of what they're going to do, what they propose to do, but it might only be that they haven't explained it well. But if you're the proposer, your job is to explain everything such that it can't be, such that it can be understood by an educated person who doesn't know about your particular field. So I know a lot about medicine. I'm not a doctor, I'm not a physician, but I don't know specifics about the clinical aspects of rheumatic disease. And that has, so everything that's related to the research has to be explained such that someone like me, who knows a lot about research design and enough about medicine, but not about the details of rheumatic disease, can understand why what you're planning to do makes sense, how I should know that it's going to work out. And that's not clear. So that's a problem with this. But I brought this up because I want to show something else. Okay, so they're going to ask people, which is always a good thing to do. If you want to know what's happening to people, ask them. And so I like that. They're going to ask them, have you had a flare of your rheumatic disease? And have you been vaccinated? And then try to put together, are the flares happening close to the vaccination? So this is a schematic of the design. Let me find the part that I wanted to show you. Okay, so how are you going to get subjects? How do you do this? Is the fancy word, the jargon word is recruiting. I think it's an interesting term that researchers use because it makes it sound like they're putting together an army. But it's the jargon term in research, recruitment of study subjects. So subjects are going to be asked to volunteer to complete an additional questionnaire. So these are people who are already participating in this rheumatology project at Hospital for Special Surgery. Some of them will be asked if they're to volunteer to complete an additional questionnaire, and that they'll do it each time they have a flare of their rheumatic disease. And so here's the thing. In order to get them to do this, they will be told that this survey will evaluate their mental and physical health during the pandemic. They're not being told that the researchers specifically want to relate flares to being vaccinated. The researchers say that this terminology accurately reflects the range of questions being asked in the survey, and I imagine it sort of does, while at the same time will minimize reporting bias. So what's reporting bias? Reporting bias would be, well, if I know that I've been given either some new medication or a placebo, and it's meant to reduce my symptoms of asthma, let's say, and I somehow find out that what I've got is the medicine, not the placebo, maybe I'm going to be more likely to say, oh yeah, I have fewer symptoms. So that's a reporting bias. It's not necessarily that I actually have the fewer symptoms, but because I know what's happening with me and I know what you, the researchers, are looking for, I report differently than I would if I had less information. And it aims to do that by keeping subjects agnostic. I thought that's a really interesting term, to our particular interest in vaccinations. So I'm going to stop sharing. I wonder what you make of that. So the subjects will be told that they're going to do this questionnaire, that the questionnaire will have to do with their mental and physical health during the pandemic, but they're not going to be told that the questionnaire, that the research is specifically about the relationship of vaccination to flares. Okay. Thoughts?
Yes, I have thoughts. I think that it's not honest, and it's not giving the people a chance to make an informed decision about their participation. And as a person of color, as a Black person, I think that if that research had come about and then I found out that's what they were doing or that's what they were using for, or other people in my community found out, that's part of why folks don't want to participate, because there's not this transparency, or it could have just been the way they had written it, but this commitment or this dedication to a sense of honesty and clarity around communication about the purpose of what it's being used for or how it's going to be used.
And
So
you mentioned being a person of color. So how does that weigh into your thought here?
Definitely. Like, so just as you described, you say they're not telling people that this is really going to be used to measure a flare, right? I think that's the way you framed it.
Yeah. To the association between flares and vaccination.
Right. That's dishonest. Like, you're not really telling me why you're doing this study. You're giving me one reason or why you're collecting this data or what that information is. And maybe I don't want to participate, or I don't want you to decide for me how I participate. And so for me, that goes when I look at disparities, and I consider myself a very educated patient. I look at disparities in healthcare. I'm looking at how I'm treated. I'm seeing that's an abuse of power. You're taking advantage of the situation of a captive population. So am I not a thinking individual, or is the community, like, can we not decide for ourselves?
Yeah.
Why are you not giving me the information? And what's your purpose behind it? So it makes it seem more nefarious when it's not.
And I think that it seemed to me that your point about communities of color alludes to the infernal history of the American medical establishment taking advantage of, particularly of Black Americans and Black Americans' bodies, not solely Black Americans, but particularly Black Americans' bodies, and both famously not giving full information, but also taking advantage in all sorts of ways that aren't fully disclosed.
Right, absolutely. And it's not just historical. I mean, they're contemporary.
Yeah, good. That's a great point. So I'm just going to hold up this book because by my friend Harriet Washington, Carte Blanche, which just came out, The Erosion of Medical Consent. And I really recommend this. I think doctors should be required to read it. Harriet, I became friends with Harriet after she published in 2006, she published a book called Medical Apartheid, which is just devastating about that history, about the history of American medical establishment and Black bodies and the continuation of that history up to the point she wrote it, of course, which is 15 years ago. But now I talked to Harriet the other day, and she's quite clear, and she writes about it in this book, that it's still going on.
Right, and I would like to give you an example that folks on this group know that I've shared that I'm a COVID-19 survivor. I'll give you a quick question. In the hospital, I said to them, what medications are you giving me? Like, why? Because I'm allergic to medications. And they said to me, we'll tell you when you're discharged. Now I'm weak, I'm by myself, my family can't get to me, it's hard to advocate. Why can't you tell me the medications you're giving me? I have a reasonable concern about this. And I was given that that first one, hydroquinone. I'm not saying the name correctly.
Hydrochloroquine.
You know.
Yeah.
And the next day, they came out that a number of people had died in Brazil, that they felt that they were stopping that. I don't know if they gave it to me or not. And so it's not just historical context, it's contemporary. I think in the community, folks don't even realize how that disparity is perpetuated by all doctors, not just white doctors, doctors of color, also because many of them are educated in a predominantly white, in a Caucasoid way of thinking about medicine.
So I really want to put in a plug for Harriet Washington's work, and particularly this new book, the Carte Blanche, in the context that Diane is talking about, that even though medicine has come a long way, like, let's give them credit, it's better than it used to be, but it's still very, very difficult for the medical establishment to recognize the ways in which they take people for granted, and people's needs for granted, people's intelligence for granted. And thank you for that, and also for the comment about this proposal. And other thoughts about that? And maybe somebody else feels like it's okay. They are, after all, giving them lots of information about what the study will involve, and there's no danger to them. No, they're not putting anybody in danger. Maybe it's okay to not tell them everything. Just tell them most of the things.
I have a comment in the chat, says the ultimate price of research a diminution of agency and autonomy of all research participants for the greater good for all.
That's a great question. I just want to see his name, Francie. Thank you. And this is you put it really so well. This is the crux of the question. And I think that it's very easy for doctors who are trained in that instrumental thinking, trained that science is the new religion, that science is authoritative, to feel that if they can't do the very best research in the shortest amount of time, that's like saying we're throwing research out, we don't care about research. And I think the campaign that I was talking about before is one to let the research establishment know that there are many, many ways to do research that involve people fully and make them fully aware. And some of those might make it take a little longer, but they don't make it worse. And they don't they don't require that anybody's dignity be sacrificed for the sake of getting scientific answers. And I guess one more thing, that it's not either or. I've encountered so many people in the medical research business who say, well, if we can't do it this way, if you make us tell the subjects everything, they won't agree to do the research and we won't be able to get the answers. But it's rarely that, it's rarely, plus or minus odd or even that way. It's more often, well, find a way to do it, find a way to include them. And this is the campaign that I think, I know LeMay and Jennifer are trying to make happen, trying to move forward, that it's a matter of educating communities to be part, to not be intimidated, to stand up, and in the way that Diana's saying, like, stand up, like, this is it, it's wrong. Don't be dishonest with me. Don't hide information from me. So I will write something about this. I'm actually reviewing this proposal, and I will write something. But my feeling is like yours, that I see no reason why you would not want to involve the people you're working with. A long time ago, actually, when I was a baby epidemiologist and learning to, I wasn't a baby, I was learning to be an epidemiologist and researcher, I had a Marxist friend who gave me an article to read about praxis, and it changed my life. The idea that it's not the people in charge who should call the shots. In fact, by turning decision-making responsibility over to the people who are specifically the ones who are not in charge, the ones whose voice is suppressed, is a way of reforming the power structure. Like, that's how things change. So that really, I mean, that's a really hard thing to do, but it really changed the way I think about research, and particularly about the participation of people who are providing information. To me, the people who are providing, and I hope you'll say this, the people who are providing information are actually the important ones. You know, principal investigator, you're along for the ride. You happen to know how to organize the information and maybe report it and write it into a medical journal, into a paper in a medical journal, but the important ones are the ones who are giving you the information. So let me just give me a second to remind myself if there was something else I wanted to say. But, oh yeah, there's one more thing. Let's see if I can, one more thing, and then I'll be quiet and we'll have time to just talk. So let's see. This is a breakdown of enrollment. And so the CTSC requires that you show who's going to be enrolled. And some studies are great with this. And this is something I always look at. Like, are you going out of your way to recruit people who aren't white? And you know, I want that. I want to hold researchers' feet to the fire. If not, why not? Maybe you're working in a place where there just aren't any people who aren't white. Okay, got it. But that's certainly not true in New York, and it's not true in most places. So I want researchers to be proactive about being inclusive. Okay, I'm gonna zip my lip and accept when I'm answering questions, but let me give you a chance to educate me.
There's nothing in the chat, but
I know, so
unmute
people have to talk.
Yes.
Chat or talk. Otherwise, what will I know?
Okay, so hi, how are you? I'm Jazzy. I always have some crazy question or comment, please excuse me. But today, something caught my ear, and that's about science, right? And you say that doctors, you know, they believe in the strong science, and that, you know, that's pretty much it. So my question to you is, why do they continue to focus on race? Because race is not science. Melanin is science. And that is my question.
Yeah. Oh, yeah. I believe that, and I've written that the continual focus on so-called racial or race/ethnic differences in disease is a way of maintaining in people's minds a distinction that isn't real as if it were real. It's a way, there's a very, very well-known, now pretty far along in years, sociologist named Troy Duster, who about 20 years ago, 25, coined this term, the biological reinscription of race. And Duster's point is that, yeah, in the 19th century, there were lots of doctors who, in support of slavery, wrote articles and even books explaining, based on no evidence, that Black bodies were less capable, or Black minds are less capable. It was all that race is a biological thing. and Duster, looking at what's happening much more recently with genomics, sees this renewed emphasis on biological aspects of what people call race or race ethnicity, and was writing about his worry that we're really going backward, that for all that we feel more enlightened about America's horrible history with race, we're also returning race to this scientific standpoint. On the other hand, arguably, the way to, I'm not going to take sides, but the way to make an argument is to show that there are specific disparities. There are specific remediable, there are consequences of oppression, and that those consequences can be biological, and they can be remediated socially and politically, and they should be. So I think it's a great question. I wrestle with it almost every day. I think that it's a question we have to keep asking. Why should we keep talking about race since we already know there is no such thing?
So this is where I would chime in, taking a bit of Jazzy's question in terms of the science and your response in this way. I think it's important to include race and ethnicity, not because it shows biological differences about the anatomy in some ways, but without the inclusion of social determinants or the impact of oppression, then it will take you down that track, because it will be based on complexion. It's self-reported, right? We know the U.S. Customs can change the definition of who's white, who's into the country of white. Like, people who migrate to America can define themselves as white, even though they may have the complexion of people of color as defined here. Or you have people of color that appear or white passing, or can pass as white. So race by itself doesn't mean anything, right? Ethnicity helps improve and record the diversity even amongst whiteness. So we have the overall issue of whiteness not being racialized. So we need to do that as well. And so then when you look at the impact of oppression, because we know if you think about simply as colorism, or the darker the hue, the difference, the greater the disparities in care you might receive,
right,
regardless of your race or ethnicity. You cannot pick those nuances up if you remove identifiers of race or ethnicity, right? You could remove race, but not ethnicity, because you need to see the nuance. But without it, if you're only looking at that as a way of measuring. So when I go to the doctor and doctors say to me, oh, you have this and that. And I say, why do I have that? What did happen? And they say, oh, because you're Black. No, that's the return to race. Now, if we said, well, if you want to include racism, the impact of racism, and look at race, you need to know who is. So I think that the push or challenge in your opportunity, in your work, what other factors might influence the outcome or the results or the diagnoses or whatever we're studying, if we include race, ethnicity, and those other determinants.
Yeah, that's a nice way to put it. And what else? Like, what else needs to be part of the conversation? Good, yeah.
Because that becomes what's important, because we see in this time, like a lot of times when they talk about access to care or disparities in healthcare in the Black community, it's presented as if it only happens to low-income people. And the pandemic showed that it happens regardless of income.
Right.
But you wouldn't pick that nuance up if you don't ask those other questions.
Right. Yeah, thank you.
I think that's why it's so important to be very proactive. It's very important to stay continuously involved. And Phil, there's so many things that you've just said today that is just challenges researchers and challenges the research community. That's why community organizations and community groups have to know exactly what they want and bring it to the tables and support their own research and support researchers.
See, and I think that's a challenge because sometimes the community doesn't know what they want. They just know the experience. So who helps translate that desire or knowledge into the research? And I think the other presenter we had last week, she's with the Bronx CRR,
Dr. Monique Gouchard, yes.
That like her talk about the community review boards, or how they begin to teach people the language, or at least some basic understanding. What does it mean? This is great, right? So it's a few of us that are here, but how do we engage more of the people? And then how do you, she talks about compensation, or, you know, making sure that you pay the community, because that's the other way that in this push to get folks engaged, how do we pay them for their time? Because the researchers get paid for their time. How do you pay the community for their intellect? That's not often included. And I mean, I signed up for studies after this episode with COVID, and I said to the principal investigator, you want to see how folks are living in the community after COVID? Who's interviewing the people in the community? It's not just the medical, it's just not the vitals, right? And so he doesn't have a social worker yet, but that was important. So I do this effort, but I also think, like, even for us participating, I'm definitely interested in research. I want to know what doctors are studying, but I have some ideas of my own. So how do we connect? If Jazzy has an idea about a research, if she's not in the medical community, but she thinks it's valid, how do we actually connect? Not just reviewing, but saying, like, I think this needs to be researched in my community. And then how do I get to be a major part of the team? Okay, I'll stop talking too.
Well, this is Lulame. I think if you want to be a part of the team, there's several ways that you can do it. One, you can come in and just as a community person, you can represent an organization or group, or if you have an idea, okay? Part of what I do is find people at the CTSC with similar ideas. It's like we have a person from last semester, and he was interested in COVID, and he was interested in the reactions that people are having over a long period of time, post-COVID, called long haulers. So right now, I'm looking for researchers that will come alongside of him. It hasn't been easy, but I'm working on it. So if you have ideas, okay, but so for example, if you're interested in something that Dr. Alcabes, that Phillip is interested in, talk to him about it. If you're interested in something that Paul Christos, or if you're interested in something that Dr. Monique Bouchard is interested in, if you're interested in anything that some of the people that we've had in this course are interested in, or maybe not directly, but maybe on a tangential relationship, then therefore talk to them, okay? But this is what this Community Research Academy is all about. If you have an idea and you're interested and you think Paulette could possibly help you, talk to her about it. If you think Jennifer Tiffany could possibly help you, talk to her about it. That's what this program is all about. And the other thing I think is so important, get young people. Nothing wrong with aging gracefully and beautifully and all that stuff, but get young people involved. Get the high schoolers, let them start listening to this class. Let them write me questions and I'll pass them on. Write the presenters, get people involved, because you know what? As long as communities stay closed enclaves for various reasons, some of them is that things that happen in the community, and some of those are things that happen outside, and we don't allow the information to get in. But if we want to be at the table, we're going to have to be at the table and take the work that goes with the table.
I saw there's something from, thanks, Lulame. And I want to add something to Lulame. So Jennifer has a great suggestion in the chat. But I want to add one quick thing to what Lulame said. And I know we're running out of time. Read so Diane, whoever, when you have an idea of something that could be researched in the community, it's so easy now to see what's been done. Read the literature, find out who's interested in those sorts of things, and contact them. Contact the researchers. They're people, and they've got email addresses. And some of them will ignore you, but they won't all ignore you. And you might be able to invite them to talk to you.
Yes.
Like, be proactive.
I just want to read the comments in the chat for anybody that can't read them. Francine said,
Yeah, actually, okay. I could speak to mine, but go ahead with Francis.
okay, she said the search for parity of esteem is eternal. And then after your comment, she said social media is a pathway to engage.
Yeah.
Yeah,
yeah. No, what I was writing about was, this is a challenge. It's like some of these conversations, like, are really pretty. Like, I think this Community Research Academy works even better virtually than it does in person. There's like such strength in it. But the sort of networking events where we could come together with a handful of researchers that are interested in things that we've also expressed interest in. That has usually been a person-to-person, in-person event, sort of like speed dating. Like, you have a table that is focused in on, it's like patient-driven questions, or, you just have different tables and then you shift around to tables, and then you end up connecting with people who have shared interests, and you might be able to build, a planning grant out of it, or a pilot grant out of it. And I wonder how we could do something like that using Zoom, using a virtual context. I just don't have the expertise with virtual. I can sit here and, listen and talk, but I don't know about breakout rooms and things like that.
Oh, I think that's fabulous. I think that's a great idea. And I think it's doable. And I think Agnes has the skills for the Zoom in the rooms. But I think that's fabulous. Oh, I love that. Oh, I love it.
So maybe a starting point with this group would be, like brainstorming a bunch of topics that we would be interested in engaging, academic researchers about.
Oh,
all the incredible things that that you've talked about over the course of the past months.
Oh, I think that's great. Oh, I think it's great. What I'm going to do is I'm going to write it up, and we'll talk about it more. And I'll talk about it with this group before they leave our classroom. Oh, I think it's great. I love it.
Diane, what do you think? What topics would you put on the table?
So some of the things that I'm interested, one, as a long hauler, definitely interested in how, especially Black individuals who are hospitalized with COVID or had severe symptoms of COVID, how they're functioning with long hauler symptoms, but the type of treatment, like care in the hospital and care out post-COVID. And that's because I started a support group talking to folks who didn't get basic services upon discharge or referral, and folks is sort of just functioning, not recognizing they need care. Then also in terms of, I was thinking about it today, like
just to stay with that for a minute. So it sounds like, something that would look at the care or lack of care, or the quality of care in the hospital, and the quality or lack of quality of discharge care.
Right.
How does that line up with long-term symptoms?
Right. And there are a lot of pieces there that I see around that reflects disparities. So I would want to, I'm encountering that people don't understand what that means, or know when that is not treated, when they're not treated well.
Yeah.
Right. And then one of the other areas that's is diabetes. I was talking to someone, I said, there's a lot of focus on pre-diabetics, However, for people who develop diabetes or are being treated for diabetes, I know in my community, the ways that the doctors communicate with them are not specific to, like I have spoken to people with type 2 diabetes that think that they could go from type 1 to type 2. They don't know their A1C3. So it's not that they're not intelligent enough. Whose responsibility is it? So I have questions, so I have thoughts about research related to that. And then just the one that came up while we were talking, I was thinking of, I have a older sibling who was diagnosed with breast cancer in the 60s. My mom died in her 50s. So I'm curious, it made me think about how many women experience, or men experience breast cancer after the death, past the age of their deceased parent, because that's not medical history. You would know because the person didn't live long enough. So it's different ways that I see health impacted in my community. The other ways I see social determinant, people in NYCHA housing that are exposed to mold and other subpar housing issues that are not addressed by the system. And so I could go on, all types of ideas.
Okay, we are coming to an end to the class. Would love to continue this conversation, but if anybody would like to has any additional questions for Dr. Alcabes or any more suggestions and thoughts, I would love to share with the class and share with Dr. Alcabes also.
I'm going to put my email in the chat.
Okay. I will also share his email with the video tomorrow and the weekly quiz.
And I'm going to also put the name of the book, about informed consent, because I think you should read it.
Yes.
I'm going to, obviously, oh, great. I mean, I feel a little bit embarrassed because Harry's a friend, but I also just think it's a great book.
Wow. Well, all I have to say is thank you so much, Philip. I've got to go out and get the book. No, I'm going to get it as soon as I'm going to send to Amazon for it, and I'm going to read it. So thank you so very much. Everybody. Oh, it was enlightening. Thank you so much.
Thank you.
Thank you for a great presentation. Thank you for everybody who shared their ideas. It was great to hear them.
It was. Thank you.
Bye-bye.
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 Thank you, Dr. Alcabes, for showing such compassion through your journey, through your own journey. You evidenced that with great gravitas today.
Thank you.
Thank you, sir. Thank you.
Thank you. Thank you. Goodbye, everyone. Thanks to all of you, and goodbye for now. I hope I'll see you again.
Oh, okay.
We'll see you down the road.
Thank you. Bye-bye.
Cheers.